Hi all, I hope you are doing well. So, hello doctors. Today we are going to study about osteoarthritis. So, osteoarthritis or OA is the most common form of arthritis, especially in the elderly. So, the clinical importance here is it is commonly encountered in the OPD level and can progress to needing sometimes surgical management also. So, we'll see about the topic in detail. Moving on to the introduction. So, OA or osteoarthritis, it is a chronic degenerative joint disorder, and the key features here is the loss of articular cartilage and formation of osteophytes and sclerosis of subchondral bone and non-inflammatory in nature. So these are the key features in this osteoarthritis, and it is not like a rheumatoid arthritis, so it is a non-inflammatory in nature. In rheumatoid arthritis it is an inflammatory arthritis, but in osteoarthritis it is a non-inflammatory arthritis in nature, but mild inflammation can occur in the secondary phase. And osteoarthritis, it is the most common type of arthritis which usually affects our joints, and it can be referred to as a degenerative joint disease or osteoarthritis. And it happens when the cartilage that lines the joints is worn down over the time, and our bones rub against each other when the patient use the affected joints. So when the affected joints are used, the lines that cartilage will be cartilage tear will happen, and the bones will rub against each other. So when the patient use the affected joints, usually the ends of the bones in our joints are capped in a layer of a tough smooth cartilage. So cartilage is like a two-in-one shock absorber, or I can say it is a lubricant. It helps the bones in our joints to move each other very smoothly and safely. So if the patient have osteoarthritis, the cartilage in the affected joints wears away over time. So there will be sometimes a breakage of a cartilage. So over time there can be a breakage of cartilage, and because of that the patient may get a osteoarthritis. Eventually, when the cartilage is affected in the joints, the bones will rub against each other when the patient moves their joints. So this is what basically happens in the osteoarthritis. It can affect any of the joints, but mostly commonly develops in the hands, knees, hip, and neck, the cervical spine, and the lumbar spine, lower back region. So this is the common areas where this osteoarthritis can develop. Moving on to the epidemiology. So it affects mostly in common in adults more than 50 years of age, and affects approximately 10 percentage of men and 20 percentage of women over the year of 50 years or 60 years of age. And females are more predominant in the like in female, you can see many of the female patients, they will complain of osteoarthritis, that is commonly seen in the female. And the major risk factors includes are, one is age, and next is obesity, and if there is any joint trauma or occupational overuse, and because of the genetics or previous joint injury. So because these are the risk factors of the osteoarthritis. Next, we'll see common sites of osteoarthritis. So, where the osteoarthritis are commonly found. So, primarily, the weight-bearing joints like knees, hip, lumbar spine, etc. So, these three are the important weight-bearing joints, and it also affect other small joints like DIP, that is a Heberden's knots, PIP, that is Bouchard's knots, and first CMC, carpometacarpal joint. So these are the joints, other joints, small joints where the osteoarthritis can occur, but majority of the time the weight-bearing joints like knees, hip, and lumbar spines are usually affected, one commonly seen in these sites. So this is what the common sites of osteoarthritis. Moving on to the types, and one more thing. Before moving on to the pathophysiology, the one important other types of osteoarthritis you can see is primary osteoarthritis, secondary osteoarthritis. So primary osteoarthritis, like what happens here is, it is the most common form of osteoarthritis, that it develops the in the joints over the time. So especially it is like it's usually caused by a normal wear and tear of using the joints throughout the life. Because of that, the patient can develop osteoarthritis. So that is the primary osteoarthritis. When talking about secondary osteoarthritis, what happens here is, when something directly damages one of the joints, it is enough to cause a osteoarthritis. Like for example, injuries and traumas are the most common cause of secondary osteoarthritis. And other types of arthritis can damage the cartilage in the joints also. So that is the secondary osteoarthritis. So primary, it is because of the normal wear and tear of using the joints throughout the life. And secondary osteoarthritis happens when something directly damages the joints, so it can develop an osteoarthritis. So that is the two types of common types of osteoarthritis you can come across in this condition. Next is the pathophysiology. So, as I've already mentioned in the previous slides, it is like a articular cartilage breakdown. So, because of the cartilage breakdown, there can be a joint space narrowing. So, the subchondral bone becomes denser and forms crystals, forms cyst there. So osteophytes will develop to stabilize the joint but lead to pain and stiffness. So synovitis occurs in the and also due to this, there can be a synovitis occurring later due to the cartilage debris. So it is mainly caused due to the cartilage breakdown. So once there is a cartilage breakdown happening in the joints, there can be a space narrowing in the joint area, and that can become, so the subchondral bones become denser and form cysts, and osteophytes develop to stabilize the joint. So during the process, it can lead to the pain and stiffness in the joints. And synovitis also occurs in the later stage due to the cartilage debris. So this is what happens in the pathophysiology or the of the osteoarthritis. Next is the clinical presentations or clinical features of osteoarthritis. The first main is pain. So gradual joint pain will happen. It can get worsened with the activity and can relieve by rest also. Stiffness, morning stiffness will be present, which will be less than 30 minutes. So in case of rheumatoid arthritis, as I've mentioned, it's an inflammatory arthritis. The difference between osteoarthritis and rheumatoid arthritis, the key point here is, there in rheumatoid arthritis there is a morning stiffness which will be more than 30, will be present more than 30 minutes of the day. So in osteoarthritis, it is very less than 30 minutes. So morning stiffness will be present, and then crepitus and joint swelling, and restricted movements, or sometimes and joint deformity in the later stages, and reduced range of motion, and instability also. So these are the most common symptoms of arthritis. So pain in the joint, especially when the patient is moving, stiffness, swelling near the joint, and a decreased range of motion, feeling like a joint is not strong or stable enough, and a joint looking very different than it used to be. So when you see the joint reserve, you can make it out, there will be a slight difference in the joints. So these are the most common symptoms of osteoarthritis. Next is the red flags. So the red flags, not osteoarthritis. So you have, while seeing the diagnosis and taking the history, you have to see first one, morning stiffness. If the morning stiffness is greater than 1 hour, think of the inflammatory arthritis. It can be rheumatoid arthritis or ankylosing, any kind of arthritis. So here, if it is a morning stiffness more than 1 hour, it is not OA. It can be inflammatory arthritis or rheumatoid arthritis. Second is systemic symptoms. Think for any infection or malignancy. Like if there is inflammation or malignancy, it will be an inflammatory arthritis or a septic cause. And the third one is rapid progression. So monoarticular acute pain, if it is present, then consider it is a gout or septic arthritis. So these are the red flags we have to keep in mind while treating the condition or diagnosing the condition, osteoarthritis. Moving on to the investigation, so radiological findings, you can see X-ray is the investigation of choice in OA. You can see joint space narrowing, osteophytes, subchondral sclerosis can be seen, bone cysts can be seen. Um, you can do Kellgren and Lawrence grading if needed also, and ESR and CRP will be normal, and joint aspiration can be done to only if any suspicion of infection or crystals present, then you can do for joint aspiration. Then serology RAANA, so to rule out any autoimmune arthritis. And MRI and CT is not routine unless diagnosis is unclear. So if even after all these examinations, investigations, if you are not sure about the osteoarthritis, then you can go for an MRI and CT scan. So this is what the investigations you have to do while doing the diagnosis of. So, and especially while taking the history or medical history, ask for any genetic history or family history and previous injury or trauma or accidents, anything so later to that, because that can also lead to osteoarthritis. So history taking is also important. Moving on to the management part, so OPD management as well as IPD management, you can know OPD management, how you can treat the condition in OPD level. In OPD level, two ways you can do: non-pharmacological management, also pharmacological management also. So there is no complete cure of arthritis, but you can you like, because once the cartilage is gone, you can't regrow the cartilage in the affected joint. So there you can manage the symptoms. So a non-pharmacological management, patient education is very important on osteoarthritis, because of the chronic conditions, and weight loss can significantly reduce the knee load. And physiotherapy is also good for to emphasize the quadricep strengthening, and use of braces or walking aids, orthotics can be done. And also ask the patient to avoid any stairs or squatting. And that is the lifestyle non-pharmacological thing you can advise the patient, the OPD level of management of the patient condition. While coming to the pharmacological management of the OPD level, you can start first line of treatment with paracetamol. It if ineffective, then go for topical or oral NSAIDs. And short course of intra-articular corticosteroids during any flare-ups. Then glucosamine plus chondroitin, mixed evidence. And intra-articular corticosteroids for flare-ups you can advise. Then hyaluronic acid injections for limited use only, is very costly actually. And avoid a long-term NSAIDs in the elderly due to any GI, gastric intestinal or gastrointestinal or renal risk. So you can avoid a long-term NSAIDs for the case of elderly. So these are the OPD level of management, the lifestyle and non-pharmacological, and the as well as the pharmacological management of the patient. So this is the OPD management of how you can manage the condition of the OPD level of osteoarthritis. Moving on to the IPD level of management. So in when you have to admit the patient at the IPD level, when there is severe pain not responding to any oral medication, you can advise them to admit in the patient, so you can do the IPD management. Then if intractable pain despite the outpatient therapy, you can do. Then joint effusion needing aspiration, if it is needed, you can admit the patient. And pre-operative for assessment for joint replacement, you can admit the patient. And if there is any sudden joint swelling, suspect hemarthrosis or infection. So in these cases, you can advise the patient to get admitted to get the treatment in the IPD level management. In IPD level management, you can mostly go with the surgical options, like because most people don't need surgery to treat osteoarthritis, but there are some cases if the patient has experienced severe symptoms and other treatments have not worked, so then you can suggest an joint replacement like arthroplasty, arthroscopy, and a joint replacement can be done. So it is not routinely recommended, but it is a surgical option. That is total knee replacement or hip replacement for the end stage of osteoarthritis. It can be indicated in the like when there is a persistent pain, or if there is any deformity, or if there is any functional limitation. So in these conditions you can indicate a joint replacement, knee or hip replacement for the end stage of osteoarthritis. And as well as the after the surgical surgeries and post operative rehabilitation can be done. So physiotherapy can be done after the surgical things. So this is how you have to manage the patient at the IPD level and the OPD level. Then moving on to the monitoring and follow up. So how to, like, even after the OPD level and if the IPD level management of the treat condition, how we have to follow up the this thing, the patient. So reevaluate the medications for, like NSAID side effects or anything is there. So reevaluate the medications you have given. The track the progression and plan for surgery. So even after you like started treating the patient on the OPD level, have a track of the progression. If in case if it is in severe, then plan for a surgery. And monitor the joint function and increase physical activity. Ask them to do physical activity, slight activities, so that it will help them to prevent from getting another osteoarthritis. So these are the regular follow-ups you have to do after the during the treatment procedures and after the treatment procedures. Next is the complication. So, the complications of osteoarthritis, the most four important things are: first is reduced mobility, because in the severe conditions of osteoarthritis, it can lead to reduced mobility, which will lead to risk of DVT and osteoporosis. And if there is any side effects of chronic NSAID use, like renal dysfunction, peptic ulcers happening, that can also be a complication. And in falls in elderly due to instability is a complication, a joint deformity, and sometimes few patients will get affected with psychological impact due to the disability. So depression or poor quality of life can also be a complication of osteoarthritis. Now we'll see how osteoarthritis is different from the rheumatoid arthritis. So osteoarthritis, you can see onset will be a gradual onset. In rheumatoid arthritis, it will be insidious. Pain, it will worsen with the use, and pain will improve with the use. In osteoarthritis, when the patient is continuously moving the thing joint, then the pain will be worse. But in rheumatoid arthritis, the patient is advised to improve the with the use, like you have to ask the patient to move. And in morning stiffness will be less than 30 minutes in case of osteoarthritis, and rheumatoid arthritis, the morning stiffness will be greater than 1 hour. And in osteoarthritis, the joints will be asymmetrical and weight bearing, and in rheumatoid arthritis, joints will be symmetrical and small joints. And labs reports will be normal in osteoarthritis. In lab reports in rheumatoid arthritis, there will be ESR and rheumatoid factor will be elevated in case of rheumatoid arthritis. So that is the important key features you have to keep in mind based on what osteoarthritis is and what is rheumatoid arthritis. The next thing you can we'll discuss about the prevention and early intervention. So the one thing you have to do here is how to prevent the condition. So there are two types of prevention. One is primary prevention, and as well as the secondary prevention also. In primary prevention, you can see you can maintain a healthy weight, avoid joint overuse, proper ergonomics can be done. And in secondary, you can do the early physio for injuries. Screening in high risk groups can be done to prevent the conditions. The next way, the best way to prevent osteoarthritis is to maintain a good overall health, including avoiding tobacco products, doing low impact exercise, following a diet plan that is healthy for the patient, always wearing a seat belt, wearing proper protective equipment for any activities like sports or workwear, or whatever they are doing. And then regular follow-ups and checkup as soon as any notice as soon as the patient notice any changes. So we have to advise the patient to have a regular follow-up with the concerned doctor. Next is the summary of the osteoarthritis topic. First important thing, osteoarthritis is a degenerative disease, is primarily affecting the weight bearing joints, and early recognition, education, and lifestyle modification very essential in treating the osteoarthritis. And it should be a clear understanding of OPD versus IPD approach. So you should have a clear approach on when you have to do OPD management, when you have to do the IPD management of the condition of the patient. And joint replacement has an excellent outcome in advanced disease. So if there is if it is a severe case, then you can go for a joint replacement. And the next one is most important, prevention is the key in high risk groups. So you have to advise the patient to know, or like educate them how they can prevent from getting infected with the condition osteoarthritis. So this comes to the end of our topic, osteoarthritis. I hope we got a clear picture regarding the topic. Thank you so much.